So good evening all. Warm welcome to all the participants for today's special virtual CME to commemorate Women's Day. Warm welcome to our eminent speakers, Dr. Lakshmi. She is MRCOG from UK. Proudly to say she is my batchmate in MMC 1986 batch. Highly intellectual doctor she is and very generous. In that, she is one of the major sponsors for our charitable foundation. Thank you, Lakshmi. She'll be joining along by Dr. Subha Karthikeyan. She is DIPNB Pediatrics, AB Pediatrics, and she is now attached with M Hospital, Chennai. Welcome, madam. Also, warm welcome to our past president, Dr. Jairam sir, and also warm welcome to Ms. Soumya of MedPiper Technologies. She is organizing this virtual CME in a wonderful manner. Thank you, madam. And today's topic for discussion will be perinatal care for preterm. So preterm is one of the biggest challenges for any neonatologist. Preterm is one of the second leading cause affecting the infant mortality rate, I think so. First being birth defects, second preterm. So at present the infant mortality rate is around 32 per 1,000 live births, I think so. With so much advances in modern medicine, we are able to maintain the NMR, that is neonatal mortality rate, as 26 per 1,000 live births. So today's topic will pave way for many interesting discussions. So let's sit back and enjoy today's academic feast. So handing over the platform to two eminent speakers, Dr. Lakshmi and Dr. Subha. Welcome, madam. You can take over, madam.
Sure, I'm going to share the session which is being pre-recorded by us.
At the outset, I would like to thank IMA Villivakam on behalf of Dr. Subha and myself for giving us this really great opportunity. Within obstetrics and neonatology, we face many, many challenges, and the women also are quite overburdened when it comes to certain issues like preterm. So we felt this is a good topic to bring to discussion in this IMA forum, and we thank you immensely for this wonderful opportunity. Why did we choose preterm? There is a very huge problem with preterm births globally. And not only is it a global problem, we know India has 18% proportion of all live births, which means 23% of global preterms are in India. And the WHO has now set a goal that we should have a 50% reduction in the mortality from preterms in the year 2025, which is just around the corner. A lot of work has gone into this area in both the government and the private sector, but we still are left with many challenges. And we felt this will be a very helpful forum to disseminate the current progress. What are the challenges a preterm poses? It poses death, morbidity, and a huge cost. So if you look at all newborn costs, 60 to 70% globally is because of preterm babies. And neurodisability is a lifetime thing for the family and the child. I'll just very briefly go through obstetric care, and then we will have Dr. Subha help us manage these babies from the neonatal perspective. So when we talk about preterm, we tell of anything less than 37 weeks. And this we put into three categories. If it is less than 28 weeks, we call them as extreme. If it is between 28 to 32 weeks, we call them very preterm. And between 32 to 37 weeks, we call as moderate to late preterm. And if this is a natural onset of delivery, we call it a spontaneous. If for some reason we need to start on the delivery at a preterm gestation, we call it as induced. How do we tackle it as obstetricians? We have got some tools to screen, and which is mainly risk assessment and some scans. Some preventive tools we thought were working, but we now understand they don't work very well, and the management. So if we look at risk assessment, all pregnant women have periodic risk assessment in all the antenatal visits. Anyone who has had a previous preterm labor or a preterm rupture of membrane is at the highest risk for having a preterm delivery. However, our goal is to prevent the very first preterm delivery itself. So this may not be helpful in all situations. But if you look at this long list, the longest list is the social issues over which we as medical people have only some control. But it is very important to acknowledge that things like domestic violence, drug misuse, smoking are becoming very huge issues in our society, which we don't speak much about. And I think every doctor has a responsibility to look into these issues, because unless they are addressed well before the pregnancy, things are bound to escalate into further and further problems. Pollution is another area where there is some work happening, but still we have limited understanding, and we just call it as healthy lifestyle helps to give the best outcome to a pregnancy. Obviously, other gynecological conditions like having uterine abnormalities, where a fibroid uterus or polycystic ovary causes hormone imbalance, can contribute. But sadly, in a vast majority, it occurs in low-risk women, which means somebody will think their pregnancy is going to go absolutely well, and then they will have a preterm delivery. And we as medical people only tend to start a preterm delivery only in 1/3 of them. And most commonly, it's preeclampsia, wherein it is very helpful both for mother and baby's health for a delivery to happen. So we are now going to look at how do we empower women. We can only empower them by telling them what a preterm labor can be like, which is pain, either like the entire womb feeling hard and crampy, or sometimes just a lower abdominal pressure feeling, or sometimes it's just like a mucus, just like a glue-like very thick discharge that comes through the vagina. Some bleeding, some spotting, it may be sometimes very small amounts, or just that feeling of something is coming in the vagina. These are symptoms we keep on telling the pregnant lady so that anything she will come immediately. The new tool we have for assessment is the cervical length assessment, which we do on ultrasound. This is with a 2-dimensional ultrasound where the probe is placed in the vagina, and this organ we are seeing in the middle is the cervix. From the internal os to the external os, we take a measurement, and this helps us to assess whether it is normal, or when there is a problem, we see it is shorter, which is usually is less than 35 millimeter, or here there is some shortening, but there's some white particles we see just above it, which we call sludge, or we see the opening with the sludge in the transverse section when the cervix itself is looking normal in length, or you can sometimes see what we call funneling, which is the top beginning to open up like a funnel, or here is the advanced where she's already in 6 centimeter dilatation. So ultrasound has become a very, very useful tool in giving us some idea prior to things happening and also while they are happening. So with this in the background, what we do is, if it's a low-risk woman, we go with a vaginal scan, and if it is normal, we just continue vigilance for the rest of the pregnancy. But if it is somebody who's got risk factors, like how we mentioned in the history, we continue doing the cervical scans periodically till we are further into the preterm gestation, and we also screen for infections. We tried many interventions, which is like treating vaginal infection, treating asymptomatic urinary infections, or giving dietary supplements. Now we know none of them work to prevent preterm labor. There may be a small role in treating fungal infections to reduce this risk, but that risk is still not fully reduced. So the options we have is either to put a stitch in the cervix, which we call cerclage, or to use progesterone hormone. And these two are the preventive tools that work. And sometimes we use a combination of both. However, if we are now out of a preventive scenario into the management, then it becomes more difficult because there is a high probability in delivering soon after symptoms start. However, not all will deliver. Like how you can see, when there is pain, maybe only up to 20% will go and deliver the baby. Whereas when membranes rupture, up to 60% can deliver, which still means a proportion may not deliver. So we give medicines like nifedipine and atosabine that will help for preventing the pain progression. And we also give antenatal steroids and magnesium sulfate. And possibly this is the one slide that must be written in gold for this entire presentation, because this is the one intervention that makes the best outcome possible for the baby. We'll now ask Dr. Subha a few different scenarios so that we understand the neonatal implications, because as you can see, this is not a single-handed approach to care. Everything in obstetrics is perinatal, and more so for preterm. So we look at an extreme preterm baby. Dr. Subha, this is a baby that we recently looked after, who was a 24-week delivery. If you look at her background, we understood she had a high risk. And that's because the previous delivery just about a year and a half ago was a 22-week miscarriage, which was extremely devastating to her emotionally. She's a 34-year-old, otherwise fit lady with a single pregnancy. This time, because of what was a high risk for preterm, we started with extensive, evaluation. But even before the extensive evaluation, symptoms came, which was bleeding. And then by 23 weeks, she became more symptomatic. And by 24 weeks, we could not do anything more than just watch a delivery happening rapidly. And I'm sure you didn't appreciate us when this baby came at 6 o'clock in the morning. So highlight the immediate care for us.
Okay, so the biggest advantage here in this child was born in M or a level 3 center, where a 24-weeker as small as 700 grams could go home now and is about 5 kilos now at 4 months corrected gestation. So what it means to be delivering in a level 3 care is like, first is preventing hypothermia. These babies, just imagine a 700 grammer coming out with no subcutaneous fat or so much insensible water loss. This slide on the right, which you see, this is the cling wrap we use. A small, anything we can use, a plastic bag, which is a food grade plastic bag, which just goes around the baby without even drying up the baby. It's supposed to maintain the temperature so well till the baby is transferred to the NICU under a warmer or an incubator. It has proven so effective in the studies. Until then, we had so much hypothermia going on at the time of transfer from the labor room to the NICU. So this is the first intervention which can be done. And once its baby's in the NICU, baby goes into an incubator. It could be an incubator or an open care system, which is a warmer. Secondly, delivery room Cpap. So we all know that all these babies have deficiency of a substance called surfactant in the lungs. So earlier there were studies saying the surfactant should be given in the delivery room itself. But now we come to know that what we have to do is to keep the lungs open till they go to the neonatal unit, and based on their oxygen requirement, we give the substance surfactant or we do not give the substance surfactant. So for keeping the lungs or the alveoli open, we give what is called the PEEP, post end expiratory pressure. This positive end expiratory pressure, sorry. So this is delivered. We can't give it by a self-inflating bag, which we normally use to bag the baby. We have to use the neopuff. This keeps the alveoli open, and we can transport the baby with this neopuff to the unit and then change the baby to what is called a Cpap. I'm very sure all of you would be knowing what a Cpap device is. It's a machine which gives just a peep on the baby's nose. So they say gestations even as low as 24 weeks, if delivery room neopuff or Cpap is given, these babies might just need surfactant alone, intubation only for the surfactant, and then they can be the tube, endotracheal tube can be taken out and they can just go and Cpap. But why? What is the advantage? The intubation and the ventilation can cause lung injury and cause chronic lung disease or bronchopulmonary dyspnea. But doing what is this is called non-invasive ventilation. These babies end up having less BPD or no BPD at all and have good, healthy, growing lungs. So this can be done only when the baby is in your own delivery room and you transport the baby with a neopuff to the NICU and immediately connect the baby to the Cpap. Then
So,
final important.
Sorry to interrupt. I think the first point is 700 gram. At the start of my obstetric career, we would have called it a miscarriage. So you all have moved the frontier so far. 20 years ago, we only ventilated babies and ventilated them for months together. And this too has moved. So I think there is a lot of new advances that have helped for the care, isn't it?
Definitely, definitely. Lot of studies. That very important key issue after dealing with the ventilation and hypothermia part is a feeding issue. So earlier we used to put these babies on total parenteral nutrition, which is called TPN, in which lipids and proteins are given through the intravenous route for weeks together, and they end up with cholestasis because of the liver getting involved because of all these lipids and proteins. But now we're able to gavage feed them right from the day of birth. So if the mother is there in the same hospital, we can encourage her to pop in a few drops of colostrum. If it colonizes the baby's tummy, they say these kids can tolerate feeds faster and we don't have to give them TPN for months together. We can even establish feeding in a week and they can come off all their intravenous catheters and be only on tube feeds till they're ready to open up their mouth and take Pala-day feeds through their mouth and then transition to breastfeeding. This actually decreases infections a lot because the central venous catheters, which goes through their belly button and through the IV, is all carrying infection, which is in their skin going in directly into the bloodstream. That can be dramatically decreased. And the concept of KMC, which is fabulous, where the mummy, as you see in this slide, where the baby is cocooned with the mother all the time, actually makes the baby grow better and have less apneas, which we call for preterms, and they grow very well and less infections. So these are all the wonders of keeping the mother in the same hospital and letting her room in with the child and come and visiting very often, and all the other technologies which can help them end up with less BPD or less chronic lung disease. Okay, so once everything is done, the baby is on Pala-day feeds, ready to go home. Infection is the important thing which we have made sure we have treated, and the baby is having no more infections. The main things which is going to tell the mother when you take the baby home is the baby okay? Is my child going to be developmentally normal after going through such a stormy course in the hospital for 100 days? So we screen the head because less than 34 weeks, most of the preterms have certain areas around the ventricles where they can bleed. This is called the germinal matrix, which does not mature till 34 weeks of gestation. So all these babies are more prone for bleeding in that area and also bleeding into the intraventricular cavity. So we screen all babies less than 34 weeks, and the bleeding is chances or the percentage of bleeding is higher if the baby is more premature, more for a 24-weeker compared to a 28-weeker. So we screen them at 7 days when the maximum amount of bleeds occur, and before discharge, where we want to make sure there are no parenchymal injury also to make sure the child is okay. So this child had a normal cranial ultrasound, thank God. And next one is called the retinopathy of prematurity. So they have fragile eyes. So the retina of these newborns, where on exposure to oxygen, they vascularize. This abnormal vascularity causes vision problems to these babies and finally can cause detachment of the retina. So we screen them starting from 4 weeks of age to make sure the retinopathy does not obstruct vision. And if it does, then we laser them early in life so that the vision in the long run is not affected for these babies. This is done at the bedside by ophthalmologists from the centers with expertise. This baby ROP was also fine because we were very, very vigilant on the amount of oxygen we are giving these babies all the time. Finally, hearing, which is another sensory problem, sensory issue, which the child needs to have it proper for the child to develop normally, like cooing and babbling. That is also a screen for all these babies. With all these screening and all these preventive and treatment measures, the newborn is given, the preterm is given to the mother to take home, assuring that it will be followed up periodically to make sure the development is normal.
Thank you, Dr. Subha. This particular situation, we delivered at 24 weeks. And if you look at the gestation, the baby was almost full term and a day or so when the baby was ready to go home, isn't it? So that's a long course, but we can understand that even though it's a long course, the technology is advanced only for certain aspects of care. A lot of it is hands-off and just being very, very careful and allowing nature to help the process, isn't it? Unlike very high-tech 15 years ago, things have now advanced and we are now in a stage where we definitely need a level 3 unit. But in the level 3 unit, the amount of technology used is very, very different. Is that right?
Very true. Very true.
I think we spoke about in utero, ex utero transfer, which you very nicely mentioned. What were the advantages? So we will just now move on, just for want of time, to another scenario. And just briefly, do you want to add about ex utero transfers, Dr. Subha? That is when a baby is born in a center where there is no level 3 care. Is it possible to safely shift them?
Definitely. definitely we can shift them. We do have the constraints of initial can't do the Cpap. We have to intubate these children for transport, and transport in a fragile 700 grammer can be risky for the baby with all those jerks and and things like that. But if we could get them earlier, the better. We can still do the best we can. Even though, but the only other thing is actually, as I was putting, it's on the slide, is like just before birth, the bonding of the neonatal team with the parents matters a lot, because they are with the obstetrician's hand for whatever 24 weeks, and then suddenly 2 new faces come in and say, I'm the neonatologist, this is this, and they get all zapped up. Poor, I don't blame them. So in a in utero transfer, if there is the other baby was here for 1 week, the mother was laboring, every other day we as a neonatal team could go address to the mother, what is going to happen, what are you looking at, this baby might stay for this long, this is our neonatal unit, the baby will be on. All those things we will not be able to explain to them, but in the time goes, once the parents get to know us, and we can develop a rapport with them.
And also the rapport between the obstetrician and neonatologist, isn't it? If ever we obstetricians can sleep well, a lot of times it's only because you all are awake and looking after those babies. So I think that's a huge team effort. And also credit to all our nurses who do such a good job in NICU, because they are really the pillar and the rock to the whole situation.
Definitely.
Okay, we'll just touch on few issues like which are the main complications. I would like to use this case to discuss about infection, Dr. Subha. We have a similar scenario to the first case, wherein we have the first clue that there is a problem for preterm at around 22 weeks because there is an opening in the cervix that we noted. This lady had risk factors. She was an IVF pregnancy, she was obese, but this was her first pregnancy. And then we were very vigilant for infection. We gave a course of antibiotics, and routinely when we suspect that there may be a higher risk, we keep screening with vaginal swab and urinary cultures. They did not show anything initially. However, the blood test, if you can see, showed a progressive increase in the total count over time. And also there was a shift in the pattern for more of neutrophilia towards the 26 weeks with a higher CRP. So we were getting very worried because you have an open cervix, which means the infection from the vagina can potentially go up. The membranes are still intact, which is good, but still there is a higher chance for infection. And the only infection we could identify was Candida. And by 26 weeks, 2 days, she herself spontaneously had pain, and which stage we had already covered her with steroids. Then we gave her magnesium sulfate, which we said were the 2 main pillars in obstetric care, but she went on to deliver. And the placenta confirmed chorioamnionitis. So here we have tried to hold on to a baby because we didn't want a 24-week related implications, whereas we have taken her 2 weeks beyond, but we have had an infection scenario. So have we done any help to the situation, or have we put this baby at a disadvantage? This baby was 800 grams, and you were able to discharge 2 months of age at 2.2 kg, whereas the other 24-weekers stayed for so much longer.
Definitely, even 1 day means a lot to these preterms. A 24-weeker and a 25-weeker have a really huge difference in outcomes and the way they behave, starting from skin maturity to lung maturity. And as you said, with antenatal steroids on board, time for it to work, with max sulfate on board, with time for it to work, it's wonderful. I think we've done a great job. I do understand there was some amount of chorioamnionitis, but for which we're going to look at what implications it can have on the newborn. So preterms per se can have are definitely at higher risk of sepsis, which is called infection, compared to term babies because of immaturity of all the organs, including the immune system. So they can have infections of within the first 72 hours to 7 days. It is called the early onset infection, and late onset after 7 days. So the early onset infections are the ones which can occur if the maternal infection is in place, like chorioamnionitis in this case. Mothers who have prolonged rupture of membranes in which there is no organism identified, who have been treated, but still there is a prolonged preterm rupture of membranes. Late onset infection is basically whatever the skill or colonizing organisms which are introduced into the baby because of our catheters and lines and caregivers hand carrying the infection. So now talking about early onset, we know that in the West, early onset infections are mostly group B streps. But here in our India, we see a lot of gram-negative infections as early onset, early onset infections. So who are at risk for infections in the studies quoted for preterm are male neonates have higher risk, outborn admissions who are transferred and have higher infection rate, need for prolonged artificial ventilation have higher infection rate, preterms as we spoke about, and premature and prolonged rupture of membranes are the risk factors. So if you go by gestation, both early and late onset infections are more in the lower gestations compared to the higher gestations. So higher in the 25-weeker category compared to the 29 to 30-weeker category. And these are the West, the data from the West, but we might have a higher incidence of early onset infections in India. But we see that the lower gestations are more affected. Risk factors, as we did talk about early onset infection, is more of what is in the mother, which comes to the baby. Late onset is baby from caregivers and environmental and things like that.
So from this slide, we can understand the higher proportion are generally late onset in terms of the newborns being affected, isn't it? So
that is definitely.
Hopefully, with effective communication between obstetrician and neonatologists about the infection profile of the mother, we will be a little bit more aware that this baby is at a risk for early onset infection, isn't it?
That's right.
And hand hygiene is something where the whole world has now hopefully become an expert after COVID. And I, for one, am personally very scared to come into your NICU because I know you will always watch me. And unless, we have washed our hands, we have actually been very careful to be there for the least minimal time. You never let any of us inside. And I think that is very cardinal principles of intensive care everywhere, isn't it? But more importantly for newborns. So would you like to just sort of illustrate the other measures that you take, Dr. Subbu?
Definitely. Hand hygiene, as Dr. Lakshmi insisted, is the main part. If you do proper hand hygiene, we can decrease more than 50% of our NICU infections. Entering NICU, before handling baby, after handling baby, after touching the file, every point of time, if you adjust the warmer and then you come to handle the child, you have to do hand hygiene. So that is very, very important. Next important thing is, we all know these children, these little neonates end up with lines through their umbilical veins and arteries. So by initiating, this is basically because they need total parenteral nutrition. So if you could initiate feeding earlier and get them off these central lines, that will be awesome. Then they will have very less late onset infections. No lines, just gavage feeding, they do very well. And very, very judicious use of antibiotics based on the sensitivities in our discussing with the microbiologists, and the less the duration of antibiotics, the better to the baby. And other thing is, these extreme preterms should be isolated, either in a separate room or, if possible, in a good setup. An incubator would work wonders to prevent them from infection, and one-to-one nursing, if possible, which will really help. And there are some evidences about pre and probiotics, which are all in a debate. But these initial measures, starting from hand hygiene and off central lines, are the must, which will really, really prevent infection, late onset especially.
So by the end of the second scenario, I think we can conclude we remain good friends. And there is a lot of communication. There's a lot of administration, fair amount of technology, but a lot of going back to basics now as part of fundamentals in neonatal care. So let us look at this, because sometimes we have a lot of new surprises after delivery. And this is the area where a lot of times there is a feeling the obstetrician did not do enough, or the neonatologist did not do enough. They're saying something new. So let us see how this is going on. This is a mother who came to us from South Tamil Nadu because she herself had a subclavian coarctation, which was entirely asymptomatic. So she really came to our center because of a potential for the mother needing a cardiac input in the pregnancy. However, that didn't give any trouble. But she had such a huge abdomen because of significant polyhydramnios. and all our measures to reduce that fluid by giving indomethacin, because that reduces the fetal kidney excretion of urine, which in turn will reduce the fluid. That's how we postulate its mechanism. Did not actually work. We scanned repeatedly. We could not find any obvious cause of infection or abnormalities in the baby, but that was something that was already always in our background. So we prepared for delivery by giving steroids, because when the uterus is really large, very often they go into spontaneous labor. And then because of a combination of obstetric reasons and pain, delivery happened at 35 weeks. But we thankfully now are out of your 700, 800 grams, and we are giving you a 2 kilograms. So at least we won't feel so bad that we didn't grow the baby in the uterus. But is that growing and is that gestation enough is what this case will illustrate. What did you encounter?
So we thought, okay, fine, there is a 35-weeker, 2 kilo. Actually, I shouldn't say this, but earlier 35 weekers, 2 kilos were still very preterm. We say, oh, wow, they're near term. I have a 2 kilo baby, nothing to worry. Came out crying, didn't have any respiratory issues. We started feeding the baby right from the day one with some donor EBM, and then the mother started giving some milk. But the point was at 48 hours, we were in for a surprise. One thing was the baby had a 14% weight loss with so much polyuria. So we thought, okay, a preterm, a 35-weeker, having an immature kidney, having a lot of tubular fluid loss. So we presumed that, and we did a set of electrolytes and a metabolic panel. When we looked at the electrolytes, we were shocked. Normally, a preterm who has a lot of free water loss and insensible loss has a high sodium. But this baby had a low sodium, a low potassium, and a low calcium with an elevated bicarbonate and phosphorus. So this meant a hypokalemia, hyponatremia with metabolic alkalosis. Then it all struck. This mother had a maternal polyhydramnios along with this dyselectronemia, which all fitted into neonatal Bartter syndrome. So it was a surprise diagnosis, but then at least we could come to a diagnosis and we could help this child along with genetic and nephrology help.
Dr. Subha, I know we tried antenatally with indomethacin, and just for want of time, we just mentioned we tried that postnatally also, and that was your mainstay of treatment, isn't it? Because of trying to adjust the urine output. Yeah,
that's right, because of prostaglandin inhibitor. That's right.
But finally, the outcome based on the genetic type was still quite dismal, isn't it? Which is very, very devastating for all of us. How did the family manage?
They didn't take it well, because after the genetic diagnosis, out of the hospital by the time the genetic diagnosis had come. But we did tell them that it's it will end up with chronic renal disease at the end. But already they're battling with this child with giving the electrolyte supplements and feeding and things like that. So I think it's not, they've not taken it in yet. So hopefully they get the strength to handle it as it goes. So just to give you a gist of what do we look at with maternal polyhydramnios. So this has been already screened by the obstetricians because they have a list of it, looking at genetic and fetal, mainly fetal malformations, maternal diabetes, multiple pregnancies, fetal anemias because of high drops with rhesus, and all the viral infections which can present, and Barters and neuromuscular disorders.
Thank you, Dr. Subha. We will just touch one very, very important aspect and then wind up. This is where we have more than one complications. This is a mother who required assisted conception, then went on to have a twin pregnancy, and then had babies that were not growing similarly. This is what we call discordance, when there is more than 20% difference in the weight. But for some reason, between 33 weeks, when the growth restriction was identified, she was lost to follow up in the hospital. And then when she turned up at 35 weeks, it became necessary to deliver because of further worsening of Doppler changes, which had happened over the 2 weeks' time. And then she comes only at 2 years of age with a baby that has significant neurodisability, whereas the other child is fine. So now we have given a preterm. She's got 2 to look after, one with every care needed to be given to that child. And this is when we all really feel, if only those 2 weeks we had an opportunity, things will be better. But we already know that It is always a problem whenever we deliver, isn't it? But this was possibly, for some reason, an opportunity missed. How do you progress from here?
We are asked, this is about fetal. So why this twin A was affected more than twin B is one thing. Is we see that it is a 1.2 kilo baby compared to the bigger twin, which is a 2 kilo 35 weeker, right? So how does fetal growth restriction affect the child? Right from its intrauterine itself, they have Doppler changes, which compromises blood flow to the different organs. But after birth or perinatally, what all happens? These growth restricted neonates have higher risk of asphyxia because they're already in utero hypoxic because of all these Doppler changes. They can have asphyxia, meaning difficulty. They did not initiate breathing immediately after birth, and they need extensive resuscitation to resuscitate them. And because of these, as you see in the picture, the lack of subcutaneous fat and very thin and fragile skin, temperature maintenance is a big issue. They don't have enough glycogen stores in the liver, so they become very hypoglycemic. So it takes a lot of glucose load for them to keep their sugars up. And hyperviscosity called polycythemia, all because of lots of RBCs because of the hypoxia in utero. And immune system is very down. So they are prone for infections. And with the Doppler changes, the biggest challenge with these little ones is necrotizing enterocolitis. This is an infection in the tummy which affects the walls of the intestine. And if it affects the neonates, they can go into intestinal gangrene itself. So feeding becomes a very, very big challenge for these babies. So these are the implications we look for. Again, this baby, what we saw was neurodevelopmental delay. So what is a neurodevelopmental delay in a baby? So they say, oh, baby has head lag, does not do what the other twin does, which is appropriate for their age. So normally itself, preterms itself have some component of neurodevelopmental delay, which they can have based on small gestation. But preterms who are having fetal growth restriction, that is, who are not appropriate for their age and they're small for gestational age, or have higher chances of the same neurodevelopmental delay. So their lower scores of cognitive is, they do all the scoring with different spheres and find out how the child is acting in different spheres. Then they end up finally having school difficulties. They can have gross motor, meaning walking, mobility, running, those kind of changes. Or they can have behavioral changes, attention deficit problems and depression and anxiety and hyperactivity, and definitely the growth failure. Severe IUGRs in which both the weight and the head circumference are compromised in utero itself have very severe growth failure. So they never catch up. But if a baby is born with just a low weight, but the head circumference is normal, in which case the fetal growth restriction has occurred in the third trimester, they can have a catch-up growth with their peers after 2 years of age. By 2, they catch up with their peers. But these severely growth restricted ones cannot catch up at all. They are always small, thin-built, short babies with a lot of neurodevelopmental issues. So also going into neurodevelopmental issues in preterm, as I told you, the lower the gestation, the more the neurodevelopment problems. So everybody thinks like a preterm on a wheelchair or preterm not able to walk is just what the delay we're looking at. No, neurodevelopmental impairment has 4 spheres. So motor is what we see, child in the wheelchair, no mobility. That's just the motor component we see. Then the sensory component, which we screen at birth, vision and hearing. It's very, very important in getting their language out. Only they can hear and they can see the mother, they can coordinate and get their language skills up. Cognitive is again checking all the spheres. We have special scales for it, like developmental assessment for Indian kids. We have a special assessment which we do and give them a intelligent quotient. Cognitive is more of how intelligent, will he be able to match in regular school or not in regular school, things like. And finally, the behavioral problem. Lot of kids do well in all these spheres, but then when they end up with having behavioral problems in school, can't adjust in school, having impulsivity, anxiety, and those. So all these together, if you put, there is a huge chunk of preterm still having neurodevelopment impairment. Just walking around and jumping and playing does not mean that they are fine when they are assessed.
And Dr. Subha, just to highlight once more, we said if it is 24, 25 weeks, these problems are much higher. But just because they are 35, 36 weeks, it still does not mean they're out of the woods. Is that right? Because we're talking about a 39-weeker is so much less at these risks relative to even a 36-weeker, isn't it?
Definitely, definitely, definitely. And the biggest, that's why we have to periodically assess them. So at birth, they go home. Periodic assessment, you feel some little change when they were 2 months and 3 months, then you can do early intervention immediately. Then you see that at 6 months, they're not cooing. Oh yeah, something is wrong. Maybe hearing is a problem. Maybe vision is a problem. We can go back and check all these things and give them some answer very early than this mother who came in at 2 when the child is having a total complete head lag. So early intervention, when you see them early and then you're able to treat things, and then by the time the child is 1 or 2, the child is able to come back to what other peers doing. It should be done. That's very important.
But Dr. Subha, you already are in a dilemma because there's a lot of intensive care. Sometimes the cost is a huge burden for families. So, but they will be much happier to be less medicalized afterwards, isn't it? So they will also have their peers to compare with. The nephew only cried late. The nephew did not walk till 2 years of age. The families will say, why you're doing so much of extra care? How do you face that? Do you find most of our preterm mothers understand these are things that are mandatory for them, or there are still social barriers?
So preterm, extreme preterms, they are so bonded with us that they don't question at all. If the problem comes with these late preterms, 35 to 37 weeks, if we have a problem, then there is denial. No, he looks normal only. There's nothing, there's no problem. But then you have to explain to them what it can imply in the long run. By doing these tiny measures, the child will be totally normal when the child comes to a walking stage and things like that. So explaining, I think, counseling a lot, talking a lot, finally they get convinced. And
Thank
just
you,
the
Dr.
take home, which, go ahead.
Done.
As the important things which you have repeatedly said from the beginning of the talk is how important is antenatal steroids in these preterm mothers, which really helps in maturing all the organs and decreases the need for a lot of things in the postnatal period for these babies, which causes injury to them than good to them. Like ventilation can be prevented by this. Intracranial bleeds can be decreased. NEC can be prevented. So gut call, all these are mature only because of antenatal steroids. So, but you have to prevent multiple frequent doses. That's very important. Limiting postnatal steroids, which the neonatologist messages, non-invasive ventilation, which I insisted on, and max health, which you already insisted on.
Thank you, Dr. Subha. So Dr. Subha has given her take-home messages, and I would like to just give the concluding remarks by saying we chose this topic because this is globally a huge challenge. And we as obstetricians and neonatologists really believe that the entire medical fraternity must be aware of the latest advances, because in one way or the other, any doctor in the community is the first person that family will seek advice and reassurance from. So I think understanding the entire scenario of prematurity in the current day was the goal of our talk. And care has vastly improved. We have a huge set of things we are able to do antenatally, but many a times we still have to watch the delivery happening, in which case we have to be very clear in communicating to the neonatal team and the families what are all the background risks. And then the neonatologist has got a huge set of observations that they have to do for a very long time to make sure that things are remaining in order. But simple things like steroids, magnesium sulfate antenatally, cervical length assessment scans have been a huge landmark to help us identify well in advance. Whereas with neonatal care, things like the kangaroo mother care is so less expensive, but has been the big cornerstone of improving their outcomes too. But very importantly, though all these frontiers have changed, there are still some lacunae, especially in the neonatal, moving on to the pediatric follow-up. And I think that's an area where in India, especially, we have to continue to focus. So these pathways are very easy to see in so many books and guidelines. And the stress is so immense for everybody. But I think together as neonatologists and obstetricians, we have always been able to medically move barriers. But I think the families though they benefit from us and the support, have a lot of stress that they go through. Thank you, Dr. Subha, and I hope we will make more new frontiers and have more discussions like this. And thank you to IMA Villivakkam for giving this wonderful opportunity.
Thank you very much. Thank you very much.
Thank you very much, Dr. Lakshmi ma'am and Dr. Subha, for a wonderful update on the perinatal care for preterm. This is really a challenging issue because it's associated with a lot of morbidity and mortality. We will take care of meticulously each and every aspect. You mentioned about KMC, that is kangaroo mother care, and hand hygiene, all important to prevent the morbidity and mortality. So you have wonderfully explained both the speakers, very nice. So I thank you, Dr. Modi sir, for arranging this wonderful speaker, wonderful topic. There really is a lot of challenges for diagnosing and treating preterm babies. Very tough. This is one of the super specialty field, neonatology and all. So because this is one of the top 10 causes of mortality in death rate, very high. These kind of issues. So you wonderfully explained what are the preventive aspect and how to diagnose early. So I am very happy. I learned a lot of things from this topic, madam. Thank you, Lakshmi ma'am. Thank you, Swami ma'am. Wonderful. God bless you. Very nice. Good evening. Okay, sir.
Any questions from the attendees?
I will check any questions.
No questions so far, sir.
Yes, this topic is really very tough and needs a lot of expertise and challenges. So meticulously we have to treat the patients. Every case is very important. So obstetrician point of view, Dr. Lakshmi ma'am enlightened very clearly, and neonatology point of view, Subha ma'am explained very detailed. Thank you very much. Thank you very much. God bless you. Any questions? Any members, any doubt, please, you can unmute your mic. You can ask question to Dr. Lakshmi ma'am and Dr. Subha ma'am.
Sir, there is a question in the box. Can I take it? Which is on pregnant women assessment. So what we do is for all women at pregnancy, the booking visit, we ideally prefer it to be well before 10 weeks. So anywhere between 7 to 10 weeks, so that we can again check, is there any background medical risk factors for them? And importantly, give a full health evaluation for them at that point. And also check the weeks of pregnancy, because I think one point that we did not emphasize too much in this talk is the role of gestation in preterm. Because many a times, especially in large studies, we still have a big proportion where the gestation is not accurately assessed. And to assess a gestation accurately, we should see a pregnant woman at least before 16 weeks. Later than that, even with ultrasound, it's not very accurate. So there is a difference between a 24-weeker to a 26-weeker, a 26-weeker to a 28-weeker, so that approximate gestation is not helpful in these situations. So I think that's one thing. So women coming early helps us for that. The second thing is we keep them all informed about preterm labor symptoms so that if there's anything, they will report to us immediately. And for all women, we do a vaginal scan along with the anatomy scan at 20 weeks when we check the length of the cervix. So if the cervix is short or opening, then that also gives us a clue that these are the women we have to be more careful. That same cervix scan we continue to do every 3 to 4 weeks for somebody who is at a high risk, so that along with giving them potentially preventive treatment like cerclage, progesterone, or both together, we also get a clue that something is changing, and then we can act a bit fast. So that's how we go about it.
Yes, madam. Thank you, madam. Very nice, madam. One more question, madam. Risk of multiple steroids.
This is Dr. Shubha's favorite topic, sir. So you asked her the right question. What we do as obstetricians is that we try to time it so that we can be as clever as possible that a delivery is going to happen. But that is not always easy. So anytime from 24 weeks onwards, we have a slightly lower threshold when we are worried, because the much earlier they are, if we deliver them without steroids, it becomes very difficult, which means that there will be a proportion that will continue to not have delivered. So at a time when we again think a delivery is happening, if it is more than a 2 weeks gap, then it is prudent to consider another dose. But we should be as much able to predict well, and that is a bit of a limitation. But we don't want to give more than 2 doses. Equally, we don't want to keep on giving every 2 weeks also, because there is some effect on growth, and also the steroids bring on diabetes for the mother. The ideal time for delivery is 3 days after the steroid. That is 24 hours after completing. We give 24 milligrams over a 24-hour period. So 24 hours after completion is the ideal time. And after 7 days, the effect slowly wears off, but the effect is there until 2 weeks.
Madam, one more question in the chat box. Dr. Kundari Sankara is asking, role of prophylactic circulage in women with previous preterm. Role of prophylactic circulage in women with the previous preterm. So
putting the suture is a very helpful way to minimize the risk. However, even with that, you will have 1/3 who will still deliver preterm. So 2/3 we can prevent, 1/3 we cannot prevent. But the advantage of the suture is that it converts a painless process. That is, a woman who does not have the stitch holding the lower part of the uterus may sometimes come advanced. That is, the baby is almost ready to come out sort of situation. Whereas when the suture is there, the pain element is more, bleeding is there. So we have a slightly earlier warning that something is happening. But if we ignore that warning, the suture will tear the cervix. So we have to warn them to come very, very quickly when something happens. So surely that's a good option.
And one more question, Dr. Kundari ma'am is asking about role of progesterone. Role of progesterone.
We do either progesterone or cerclage, sir. That is, we can either give them the oral medicine or vaginal medicine or progesterone. That or cerclage, both are similarly effective. But in high-risk women, sometimes there may be a need to do both together. But ideally, one is to be done.
You prefer which steroids, madam? Dexamethasone or betamethasone steroid?
Dr. Subha?
Madam.
Yeah, we prefer dexamethasone. One reason being that with betamethasone, with most of the Western studies are on betamethasone, but with betamethasone, in the West, the betamethasone has 2 components. One is a short-acting component and acetate and phosphate. So one is a short-acting component which acts immediately, and the second one is a long-acting component, so that we can give betamethasone every 24 hours in the West. That's what all the studies say. But in our country, the betamethasone only has the short-acting component. So we don't have a proper regimen for betamethasone, even though we are, following the West, giving the Q24 dosing. So that's why we prefer the Dex. Dex, we have a Q12 6 milligram dosing for 4 doses. And there are some small cohort studies which say that Dex has a better effect on babies, decreases intraventricular beats and forehead circumference. So it has a better effect than betamethasone. And it's cost effective also. We have to use it on the centers which are thinking of cost.
Thank you, ma'am.
There was a question on COVID-19 precautions in neonatal
recommendations for neonatal management in COVID-19. Yes, ma'am.
COVID-19. So actually, if it is a term baby, it hasn't been a huge problem. We can actually, unless the mother is very sick, we can just, bring the baby out away from the mother. And then once the mother is ready to, we can, cohort the baby, co-bed the baby with the mother. And she has to use precautions like masking and, hand precautions while feeding the baby. So term babies, a lot of our mothers, even after discharge, have acquired COVID and they've just still breastfed their babies and there has been no implications on the baby. Very rarely, some neonates have developed some low-grade fever, which has resolved. Because they say the antigenic load in the breast milk is very less compared to the antibodies which are being transmitted from the mother to the baby, which is more protective. Preterms also, there are not huge data saying that they have had very major implications, but unfortunately, I have not faced any because we have been screening all our mothers before delivery here in our unit. So we've not had a neonatal COVID positive child here. But this is what studies say, that have not had huge implication even on late preterms. Extreme preterms, I'm not sure.
Can I just add, Dr. Jairam, there is a huge element of fear in the families that if the mother feeds the baby, she's going to put the baby more at risk. So families, especially in the first wave, were really forcing a separation. We also didn't know much about COVID at that time. But with the second wave, things were much better. But the first 2-3 days can be physically challenging to the mother because she's very exhausted even after a normal delivery. So I think to have a care provider who can ensure safety for the baby in terms of holding well, all that was the challenge we faced. But I think surely the acceptance of breastfeeding has got more and awareness is now much better.
Madam, one more question from Dr. Kundevi Sankar. How short is short cervix? I don't know what is the exact question.
Yeah.
How short
so
is
the length,
Yeah.
so we measure it as a millimeter length, sir. So anything that is more than 30 mm, we call it as 3 centimeters and more, we call it as norm. So anything that is less than that, we take it as a shorter cervix. But we'll have a measurement that is variable. It can be anywhere between 3 to even 5 centimeters. So if we know what is a measurement for that lady, if we check it again and if it is less, that's what we take it into considerations.
Thank you very much, Madam. Dr. Subha and Dr. Lakshmi is a crisp and clarity presentation and answers.
Thank you.
Very happy. Thank you. Very nice. Thank you, Madam. Thank you. God
Thank you. Thank you. Thank you.
Any other question in the chat box, Soumya, ma'am?
So one more, sir, on subsequent pregnancy care.
Yeah.
Was mentioned. So if anybody has had one preterm delivery, then they have a very high risk in the next pregnancy to deliver preterm. So if it is a spontaneous onset of preterm labor, then we keep doing cervix scans regularly to see if it is short and then add the progesterone. Or do a cerclage. If the cervix scan is remaining normal, we can just give them an observation pathway or a progesterone pathway. Some of them are very anxious and ask for a cerclage. That is also an option. But all three are equal options where evidence is similar. Whereas if they have actually had an iatrogenic, that is, they've had preeclampsia and so they have delivered again preterm, things like aspirin, when it's given in the subsequent pregnancy, has a much, aspirin as 75 milligram, 150 milligram, has a good risk reduction value to reduce preeclampsia in the future.
Fantastic. Thank you.
COVID vaccinations, Dr. Moti wants to know, that is suitable for pregnancy use. Preterm, Dr. Moti, what did you mean? You mean when they are for the perinatal, whether it is antenatal or after delivery, all times the mother can have a COVID vaccination. There is nothing that's.
Even if she's lactating or she's lactating, she can still have it. She's lactating a preterm baby also. We advise all our preterm mothers to get vaccinated.
Fine. Fantastic.
Thank you, madam.
Thank you. Thank you for the opportunity.
Madam, one more question. Genetic testing. Any role of genetic testing in that preterm or any? I don't know.
Genetic testing depends on previous history. If they've had a genetically abnormal child in the previous pregnancy, and we know there is a particular type of mutation, like we had this neonatal Bartus, and we have a genetic sequence which we had identified in this particular child. If this mother is planning a next pregnancy, then we can always send her to a center like, Mediscan or other centers with the genetic, where they could do antenatal CVS and get genetic testing done to test if this child also carries the same mutation. That would be an option. Anything else you want to add, Lakshmi, for genetic testing?
I think you're just wanting to find out in the situations where we will consider genetic testing. Is that correct, Soumya? Yeah.
Yes, doctor.
Yeah,
Yes.
we go more by it may not be always related to preterm. In pregnancy, we have two types of tests, times when we do genetic testing. One is we do routine screening. That is for all pregnant women. It is recommended to screen for Down syndrome because that is the most common genetic condition that occurs. So that test is with a scan at 12 weeks where we look at the neck thickness called as nuchal scan. And we do hormone markers called PAPA and free beta HCG. The combination gives us a risk, and we put a high risk number as greater than 1 in 250 and then offer a definite test, which is the genetic test. Whereas if they don't come early, then at 16 weeks also, there is a hormone test that can be done. but that detection is 60% compared to 90% if we do the test at 12 weeks. So we prefer routine first trimester screening for all pregnant women, irrespective of genetic history for Down syndrome. The second is clinically indicated. That is what the family history is, what is a genetic background. And that also becomes equally relevant, like what Dr. Subha said, when the baby is born, and if we notice some features, then we do a genetic test.
Madam, one more question from Dr. Kundavi. What is the extreme preterm you have delivered and looked after? How is the baby now?
This was our first case.
Yeah. Subha ma'am.
And I think we've had a 620 grammer and has done well, is well now actually. We've got doing very well cognitively and language wise. So
Fantastic.
it's the
Thank
smallest.
No, at this time, I must say the families have also been really very, very good in looking after
Very
these
nice,
babies.
yeah.
Isn't it? They do such
Just
a good
believed
job.
us like God, more than God. They just listen to whatever we say, because we periodically counsel them, and more than this, the whole team bonds with them. They send pictures of every birthday pictures and everything they share with us, every little thing, and they don't. That's very nice. That bonding is very nice.
Fantastic. Wonderful discussion on the challenges what we are facing in preterm. Thank you, ma'am. Thank you.
Thank you. Thank you very much.
Thank you for the opportunity.
Thank you.
Thank you for the opportunity. Yeah.
Thank you, madam.
Thank you.
Doctor, there is one more question in the chat box. Would you like to take it?
Yeah.
I think Soumya is conducting a Viva for us today. So that's nice.
Anemia.
She has decided to ask about anemia. And I think that's a very, very important condition because that's the most common medical disorder. And you're very correct. Actually, anemia also is a risk factor to bring on prematurity, as with all other conditions. But treatment of anemia by itself does not reverse the preterm risk. That's what we know. Anemia most of the time is nutritional, which is iron deficiency. And we screen all pregnant women each trimester with a hemoglobin so that we identify what is their parameter of hemoglobin, and anything less than 10.5, we try to actively treat. And if it is much lower, then we need to do other workup to see if there are other blood conditions and then take it.
Thank you, doctor. And the question was
okay, not you, sorry. Yes. Thank you, Dr. Selvaraj. It's a very important part of pregnancy care. And anemia is very prevalent in our adolescents also. More than 50% of our adolescents, even in cities, even in what we think as relatively higher socioeconomic strata, have anemia. So one of the goals for an obstetric care is now pre-pregnancy care, and that pre-pregnancy care is based on adolescent care. So adolescent anemia prevention is one of the very important health agendas for the country in terms of its health policy also. The question is about food style modification. I think that's a very important question, Dr. Selvaraj, because you would find that every pregnant lady's family will always question us what they should eat. And this is a question they universally ask us. And what we have to identify is the food pattern of what you eat is one part of it. The timing of the meal is the other part of it, because most families now have very varied timings when they eat. And though they say they eat well, they may have their breakfast at 11 o'clock and the lunch at 4 o'clock and dinner at midnight. So these things also are very important in pregnancy because you have to have a proper sleep along with a proper eat. And the diet should be a varied diet. It does not matter whether it's vegetarian or non-vegetarian, but what is seasonal at that time with a good amount of fruit and fiber will give all the important vitamins. The one thing that a food may not give very well is folic acid, and that takes us to the very important aspect of folic acid supplementation as 5 milligram to be given to anybody planning a pregnancy, because that helps to reduce the neural tube risk. So we suggest that before pregnancy until 12 weeks of pregnancy. Apart from this, though vitamins are generally given to pregnant lady, as a routine for a well-nourished person, it may not be necessary. As far as exercise is concerned, they must exercise because it is a high energy process as far as pregnancy and delivery is concerned. And exercise also helps, one, to prevent conditions like back pain, two, being immobile will increase risk for thromboembolism, which is very high in pregnancy. And the third thing is somebody who's very lethargic all throughout pregnancy will not have sufficient energy to cope through labor in terms of the high demand of needing to push. Their respiratory reserve will not be good enough to, breath hold and do the pushing. There is a myth that exercise brings on preterm labor. That is not at all the situation. Only a very small subgroup of preterm where delivery appears to be imminent, minimizing activity will help. But the other end of the spectrum, you have a group where they over-exercise. That also is not correct because that increases the growth restriction risk because the circulation to the placenta becomes less effective because that oxygen, rather than going to placenta, is going to the increased anabolism because of exercises. So half an hour a day is definitely allowed and recommended.
Psychological care, Lakshmi, your favorite topic.
No. Now
Lakshmi
I'm going to give it to Subha.
Endlessly talk about this because she's such a counselor for her patients. She lives for them, She's at their beck and call on the phone to alleviate their anxiety and their psychological problems. Right, Lakshmi?
I think anxiety in pregnancy is something we did not understand very well till recently because we used to always, we have always had this among medical people, and I think we should be frank. We know there are a subgroup who we think are very demanding or ask a lot of questions. But we're now beginning to increasingly understand, especially in pregnancy, it's a very high anxiety situation. So somebody that is asking questions repeatedly has to be almost put as somebody who has got depression in terms of their risk factors, because the higher the stress levels, the more the influence on the hypothalamo-pituitary axis, which means more the potential for a preterm delivery and a low birth weight, and also higher risk for attention deficit for the newborn, because they will be so anxious that they will not bond with the babies well and things like that. So I think every step to keep the family and the pregnant lady less anxious is very, very, very important. But it's a very challenging field. I don't think we have the full answers, but I think we should keep watching how they are. Some people will come into the consulting room, go back out, come back again, ask the question. They will then go and ask the nurse outside the same question. These are all triggers that they are very, very anxious. And sometimes the anxiety is because a family member has had a health problem which they're not wanting to tell us. Somebody would have had a stillbirth, somebody would have had a preterm, but they don't know exactly how to tell. I think so when we think somebody is, appearing to be overly questioning, we need to give them time, understand the situation. And we also should understand that pregnancy is at a higher risk and the baby also will be put through at a higher risk. Mother side and mother-in-law side, in our culture, putting pressure. Now I think I'm really getting cornered. Okay, I think one word answer to that is make both of them sit in the same room, because I have done that many times. I've told them, please bring your mother, please bring your mother-in-law. I want to talk to them. Because I think sometimes us telling them certain things is really, really helpful. Women are very helpless. Okay, they have no control over what they eat, what they wear, which day they can go to have the antenatal checkup, which day they can have delivery. It's all determined by somebody else. So unless we know who is the game player in the family, as perinatologists, we don't succeed much at all. We should be able to communicate to them, make sure they understand. And then that means that the pregnant lady will be supported. And many a time when there is a pregnancy complication, the women live in such fear for the rest of their careers till this child is grown up, because they feel they have brought on a problem to that child. So I think we should recognize and tell the families that really sometimes even we are helpless with all our medical knowledge.
Even neonatal, the mother-in-law has a huge say what to feed the child, when to feed, everything only she decides. Poor thing, the mother doesn't have much of a say. We have to address it to them a lot, definitely. Yeah, first girl child, second more stressed. Yeah, definitely. They're all very stressed out. If you come and show the baby, they don't even ask you, did the baby cry? In the sex doctor, in the sex doctor, in the sex doctor, they'll ask me when I come out of the delivery room. I said, whatever sex, I want to see the smile on your face. Otherwise, we're not giving the baby to you. And the father said, no, nothing like that. We just wanted to know the sex. So it's still there. I don't know how it's going to change in the long run. I think in the next Maybe the next decade it'll all change and they won't ask for the sex and they'll ask for a healthy baby. I don't know.
I think there are a lot of cultural things we have limited understanding, isn't it? And I think that also we should continue to work at, but I would agree with Subha. Now, because gender disclosure in pregnancy is absolutely not allowed. We still have the affluent who go travel abroad and see and come. That is one thing we should not misunderstand, underestimate. But equally, they try to ask us many a times. When I do scan, they'll always ask me, doctor, you tell me, I will not tell anybody. I'll say, let us both go to the jail and sit together till delivery. Then you will also see the baby's sex, even I will see that time. So I think certain things we must be very, very careful unless they know you are also very clear you're not going to say, they will somehow call it.
Thank you. Thank you.
So I think we have taken up all the questions. And I would like to thank the faculties, Dr. Shubha and Dr. Lakshmi, in detailing all the aspects of prenatal care and from doctor's perspective, family perspective, mother's perspective, and all together. Indeed, it was a great presentation altogether. Dr. Jayaraman sir and Dr. Jamoti Narayan sir, thank you for this opportunity, for this wonderful collaboration. And as I mentioned earlier, we would like to initiate another set of discussion in and around the neurological disorders and genetic care. Hope you remember, doctor. So thank you so much.